Hello and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. The Parkinson's Foundation is a dedicated nonprofit organization committed to enhancing the lives of those living with and impacted by Parkinson's disease. We focus on improving care and advancing research, ensuring that all our efforts are closely aligned with the needs and priorities of the Parkinson's community. Today, we will understand how rehabilitation professionals, including physical therapists, occupational therapists, speech language pathologists, and others work together to maximize functional abilities and quality of life for individuals living with Parkinson's. To begin our formal presentation, I would like to introduce our presenter for today's webinar. Terry Ellis is a professor and chair of the Physical Therapy Department at Boston University, where she also directs the Center for Neurorehabilitation. Dr. Ellis's research, supported by the NIH and the Parkinson's Foundation, focuses on understanding why people with Parkinson's disease experience difficulties with walking and developing therapies to help them walk better in everyday life. She holds a PhD in behavioral neurosciences from Boston University School of Medicine and is a licensed physical therapist with a specialty in neurological physical therapy. Dr. Ellis has published many articles and speaks internationally about improving rehabilitation for people with Parkinson's disease. Dr. Ellis, thank you for sharing your time and expertise with us today. Oh, your microphone is muted.
Well, thank you for that warm introduction, Krista. I really appreciate the opportunity to speak to this group. This is a topic I'm very passionate about, and I look forward to sharing this information with everybody and having hopefully a very vibrant Q&A, at the end of the presentation. So I'm just going to share my presentation here. Okay. Can everybody see that?
Looks great. We're on your disclosures. There we go.
Great. Yep, my disclosures, as you said, I have funding for research and outreach activities through NIH, through APDA, the Michael J. Fox Foundation, and MedRhythms. So today, what we're going to focus on is understanding how rehab professionals, and I'm going to focus on physical therapy, occupational therapy, and speech language pathologists, how they work together to support people with Parkinson's disease, with the goal of really, optimizing function and engagement in everyday life and, enhancing quality of life over the long term. So I'll talk about sort of what do each of those disciplines do, what is their sort of niche area, where do they have expertise, and how do they develop treatment plans that are tailored to the needs of each individual. So this little diagram here, this includes physical therapy, occupational therapy, speech therapy, and even psychology here, which I won't get into today. But, this just represents a very holistic, interconnected approach. Each discipline has their own unique expertise, but there is a lot of overlap as well. And ideally, the disciplines are working together to optimize quality of life in people with Parkinson's disease. So let's start with physical therapy. So physical therapy is provided by physical therapists, and physical therapists, they examine and diagnose and treat movement dysfunction. So basically, physical therapists are movement experts. So they diagnose a movement problem, they try to figure out what's causing the movement problem, and then address that through a variety of treatments. And some of the things that physical therapists have particular expertise in are gait or walking, things like balance, and reducing fall risk or falling. And then physical therapists also have a lot of expertise in exercise. So they, when they examine people with Parkinson's disease, they're trying to understand, their the challenges and some of the impairments, and to design an exercise program that's going to best meet their needs. This picture here just depicts a whole bunch of different illustrations of people with Parkinson's disease. And the point I want to make here is that everybody is different. Everybody with Parkinson's disease has different challenges, very different from another person. And so it's very critical to have an individualized treatment plan, developed by each of the different therapies. Occupational therapy, which I think people tend to be less familiar with. The goal of occupational therapy is to promote performance and participation in meaningful daily activities and sort of everyday roles in the home and community. So, for example, people with Parkinson's disease that are working and maybe having challenges related to the computer. People describe different things like problems with the keyboard and being efficient in typing and those sorts of things. Or maybe it's the position or the posture that people are sitting in while working, for example. And occupational therapists can examine that and figure out, well, how can we enhance someone's work? How can we make sure that people are comfortable and efficient? And they can take a look at that. Other things they do is, help people do the things they like to do, like travel or socialize, those kinds of things. To try to understand what's getting in the way or what might be a barrier to doing those things. And occupational therapists can help address those things. They also have a lot of expertise in sort of driving. They do some driving evaluations to determine whether people are safe driving or what it would need to take to get them safer driving. And then they also look at ADLs or activities of daily living, things like dressing, bathing, showering, house related activities to try to optimize people's everyday function in their home and community. And then, speech language pathologists or speech therapy is used to educate, counsel, assess, and provide treatment around, communication and swallowing and cognition. So as many people know, people with Parkinson's disease can have a more quiet voice or difficulty projecting their voice. So speech therapists can examine that, figure out what the underlying issues are, and prescribe an exercise program, to strengthen the sort of loudness of the voice. And then they can examine swallowing, to make sure swallowing is effective, and there's no evidence of any sort of aspiration. And they can recommend certain foods to eat that are more or less likely, to cause aspiration. And then they also have a lot of expertise in cognitive function. So, some people with Parkinson's disease might experience, for example, executive function impairment. So what that means is things like difficulty paying attention for long periods of time, or switching between one task and another, for example, or organizing or multitasking. So and speech language pathologists can provide some treatment to improve those things, or strategies to make it easier to do things like multitask. So a lot of questions I get, from people with Parkinson's disease is, well, what can I expect when I go to see a therapist, and when should I go? And then what will they do? What can I expect? Well, all these different therapies, whether it's physical therapy, occupational therapy, or speech therapy, when you go to see a therapist, there's a diagnostic process. They start with some either standardized measures so that they can try to understand the problem in more depth. And a physical therapist would focus on walking and balance, for example. A speech therapist would focus on communication and swallowing and thinking, and an occupational therapist might be looking at, things, leisure activities and the kinds of things people like to do, and examining what's getting in the way, in addition to activities of daily living. And then once they've diagnosed or sort of what the underlying problem is, then there's an assessment. Okay, let's put together a plan. Let's see, now that we understand what's going on and what the barriers are, there's some discussion, with people, with the patient, with the person with Parkinson's disease. And depending on that person's priorities, there's a discussion and sort of shared goal setting. Collectively you decide, all right, what is it I want to achieve? What is really important to me? And then the therapists come up with an individualized treatment plan. All right, how can we best overcome those barriers? Or how can we best, overcome those challenges? Or how can we improve this walking or the robustness of a voice or whatever it is? And then, they come up with a certain plan. And then, that leads to figuring out, okay, how many sessions might that take, to accomplish the goals? So one of the main things that I want to stress is that we now understand, and I'm sure many people listening have experienced this, that a lot of the symptoms of Parkinson's disease, are actually present much earlier than we used to appreciate. So in the prodromal phase of Parkinson's, or before the symptoms really manifest clinically, many people with Parkinson's disease experience things like REM sleep behavior disorder, or lack of a reduced sense of smell, or things like constipation, or mood changes, or things like sort of dizziness, or indicating a drop in blood pressure, those sorts of things. And people might have those actually for several years before the clinical symptoms emerge. Things like resting tremor or bradykinesia, slowness, those sorts of things. So the message here is that, because these symptoms emerge early, the question is, should we be starting therapy earlier? And the answer to that, I'll tell you right up front, is absolutely. And here's some additional data from studies looking at long-term risk of falls in people with early Parkinson's disease. And what I'm just going to point out here is right at the bottom. In this study with almost 200 people, this was done in, this was a Norwegian study. They identified that 15% of people with Parkinson's disease actually had a fall before their diagnosis. And then another 13% fell in the first year. So we used to think about falling as something that happened later in the course of the disease, but this study is showing that it actually happens early. So we should, that means we should do something about it early. Even things like moving in bed, for example. This was a study done with about just over 400 people that had early Parkinson's disease and that weren't yet taking medication. And then there were people who were at risk of developing Parkinson's disease, and that was almost 500 people. And then there were controls that didn't have Parkinson's disease or were not at risk. And in that group, you can see here, even the at-risk people, there was about, 9 to 12% had difficulty moving in bed. Probably it's more effortful, it's really slow moving from one side to another. And then 25% of people with early Parkinson's had difficulty moving in bed, whereas only 2% of controls had difficulty. So what this is showing that is there's, even just moving in bed can be, more challenging and effortful early on. And we didn't, we hadn't appreciated that, in the past. So, one of the good things about rehab now is there's much, much more robust evidence showing the benefits of rehabilitation than ever before. I'll give you an example is now there's clinical practice guidelines that outline the sort of most optimal physical therapy management of Parkinson's disease. So this is a document that's shared with physical therapists that guides practice. And what it does is it outlines, here are the critical elements that should be included in treating people with Parkinson's disease. And these guidelines are helpful to make sure that physical therapists are providing, sort of best practice, best care. to benefit people living with Parkinson's disease. So what we've learned so far is the symptoms come on early, and we have robust evidence showing, in that case, physical therapy is beneficial. There's also pretty robust evidence that speech therapy is helpful in improving loudness of voice, for example, clarity of voice. And then there's more research, emerging showing occupational therapy and the benefits of improving ADLs, for example. The problem is that not everybody with Parkinson's disease, and in fact, relatively small percent of people with Parkinson's are actually accessing these rehab services. So there was a large study done by the Parkinson's Foundation a few years ago, and looking at over 5,000 people across 4 countries with Parkinson's disease. And basically, they found that only about 35% were referred to rehabilitation services, at least one service, whereas only 25% received multidisciplinary services, so more than one service. So you can see here, physical therapy is in the middle here. This is the most frequently prescribed therapy for people with Parkinson's disease. And you can see here about 26% of people with Parkinson's across these 4, major centers of excellence actually received physical therapy. And then, what I want to point out here is that only 18% received physical therapy early in the course of the disease. So most people, when they got physical therapy, it was at the sort of middle to later stages. And that's in comparison to speech therapy and occupational therapy, in which only 3% of people with Parkinson's disease accessed these services. So again, this gives data on how many received more than one. So people that received physical therapy and occupational therapy was someplace between 3 and 9%. So if you think about it, there's other data actually, other studies that have been done as well on this topic. And in the United States, if there are about 1 million people living with Parkinson's disease, and let's say 20% receive physical therapy services, that means 800,000 people are not receiving rehabilitation or physical therapy services. That's a problem. And that's something I'm passionate about, and something work with several other of my colleagues to try to get this message out, and to try to educate both physicians, physical therapists, occupational therapists, speech therapists, and people living with Parkinson's disease, that there's really a lot of benefit in getting therapies and getting them early. So I was part of a team this initiative was actually led by the Parkinson's Foundation and Jennifer Goldman. And we got together experts in Parkinson's disease from all over the world. This was a global task force. And we put together this consensus statement. And this consensus statement provides recommendations for how best to deliver multidisciplinary rehab care in people with Parkinson's disease. And this includes recommendations for physical therapy, occupational therapy, speech therapy, among others. So you don't have to read this very busy slide, but what I want to point out is, in this consensus document, there were key recommendations. And I'm going to show you up here. Rehab services should be implemented across all stages of the disease. And then here, early referral to rehab services should be recommended as soon as people with Parkinson's are diagnosed. And this should continue with regular modifications over the course of the disease. Again, and recommending multidisciplinary services. And one of the things we recommended here, and this is based on some of the work that we've done, is that ideally, people with Parkinson's are following up with rehab providers, every 6 months to a year or so that they can have regular checkups. And I'm going to talk about that here. So the big question then is, where we want to shift, I guess, we want to shift from more of a reactive to a proactive approach to rehabilitation. So you can see here, tertiary prevention. That tertiary care is when people, for example, people with Parkinson's disease who already have the disease and are experiencing a decline, receive rehab services. And that is very appropriate. And rehab can do a lot when people are declining to help that. But what we're missing here is a secondary prevention approach, which should also be incorporated. And what this involves, secondary prevention, is when someone, let's say, was diagnosed with Parkinson's disease and the rehab intervention starts right away to prevent the sort of decline that we know that happens over time, or to slow the progression, to optimize function, to reduce disability early in the course of the disease, so people can live a sort of healthier, more functional, better quality of life over the continuum of the disease. And then there's something called primary prevention, which is basically, this is ideal, is when, people actually intervene before the onset of the disease, like, exercising, for example, to reduce the risk of developing Parkinson's or some other condition. This sort of busy slide here, what this is showing overall is these are several studies that have been done that examined the role of physical activity and risk of Parkinson's disease. These are large epidemiological studies with, thousands of people. And what they found is that adults who engaged in physical activity, mostly moderate to vigorous physical activity, had a reduced risk of developing Parkinson's disease over the course of their lifetime. So that would be primary prevention. You could say the same thing for many other conditions. Physical activity, we know, it reduces risk of cancer, reduces risk of cardiovascular disease, and it also happens to reduce risk of Parkinson's. Here, this data is an example of sort of secondary prevention. People with Parkinson's disease here who engaged in a higher level, sort of more moderate to vigorous physical activity here in the red, had a slower progression of walking and balance deficits over the first 6 years of the disease. Whereas people with lower physical activity levels had higher progression, or sort of a faster progression. So what this shows, this data, is that we should be, exercise, for example, is very critical to start early, and and be a sufficient intensity such that it can mitigate, some of the gait, in this case, gait and balance issues that arise over time. Here I'm using exercise and physical therapy as an example, but there's other literature in the speech world that suggests a similar thing. Speech exercises for the voice have also shown to be beneficial in maintaining that, the robustness of the volume of the voice over time. So what I'm really talking about here is this, in this secondary prevention model, we often refer to this, we've sort of coined this, the dental model. And the reason we call it the dental model is because it sort of resonates with people, because people are very familiar with the model of care that is used in dentistry. So, for example, in dentistry, you go to the dentist whether you have a problem or not, and you go routinely every 6 months or annually to have a checkup. And, the dentist might, for example, the dentist might find a small problem. And if the dentist finds a small problem, they can then intervene more efficiently and effectively at that point to mitigate some of the problems that could arise over time, rather than not going to the dentist and waiting until a problem emerges. So that's a similar model to what we're advocating for people with Parkinson's disease. Because people with Parkinson's disease live a long lifespan, and with the medical and surgical managements are pretty effective. But despite that, people still experience a decline over time, many, many years, decades. And so what we recommend here is a referral to physical therapy. This is the example here, but I would suggest a referral to PT, OT, and speech therapy right at the point of diagnosis. So once somebody is diagnosed with Parkinson's, we recommend that they sort of set up their team, that they go see a therapist and have an initial consultation. And then what we recommend are these follow-up visits, which happen, again, sort of every 6 months to a year, depending on the person and their particular profile. So what happens in physical therapy at the beginning is somebody, we would bring somebody in, we would do a thorough examination, and that examination is not just the motor symptoms, the UPDRS, not just the slowness, stiffness, and tremor, but we spend most of the time examining walking and balance, and and then we look and talk to people about their exercise habits and figure out a plan, an exercise plan and a physical activity plan that's going to, help optimize outcome over time. And so that might involve, a couple of visits. It usually is pretty short at the beginning. And then when people come back every 6 months to a year, we administer those same standardized outcome measures so that we can detect if there's been any change over time. We want to know, has the walking got slower? Is there any change in balance? Sometimes we can pick things up before the person even realizes it or notices any problem. And that's good, because then we can intervene and adjust the exercise program and provide the necessary therapy to be able to mitigate those symptoms. And then if you ask, well, is there any evidence to support this secondary prevention model of care? And there is. All of these studies that I just showed right here are robust randomized controlled trials showing that early and moderate to vigorous exercise helps improve walking, balance, and reduce the motor symptoms of Parkinson's disease. So the evidence is there. And now the Parkinson's Foundation has actually put out some recommendations in the form of infographics that help people with Parkinson's disease know what to do. So in this case, seeing a physical therapist, and particularly a physical therapist that specializes in Parkinson's, that's very, very important. And that, safety of the exercise program is key, and that it's important to modify and to progress the exercise program over time. And then here are some recommendations. In the public health guidelines suggest at least 150 minutes of moderate to vigorous exercise per week. And these are the different types of exercise that are recommended, for people with Parkinson's disease. Things like aerobic exercise, strength training, balance training, stretching, for example, and even things like task-specific training. Now, some people might say, well, why do I have to go to a physical therapist to exercise? I could just exercise on my own, or I could join a class and exercise. And that's great. People should, people need to exercise on their own, and doing a class helps with keeping people engaged in exercise. But It's also important to know what kind of exercise to do and how much to do and what the dose should be. So a lot of people we see come in and ask questions like, does the type of aerobic exercise matter? Should I walk, for example? Should I run? Should I cycle? Should I swim? What is the optimal dose? How intense should the exercise be for me? How many days a week should I do this? For how long? And those are the things that a physical therapist can help answer. And, a speech therapist might provide similar information with what are the kinds of voice exercises I should be doing? How frequently? How hard do I need to work? How long do I need to do it for? Those are all important questions. There are also things like other things like we call it task-specific training. Because people with Parkinson's disease have trouble with movement automaticity, because of that lack of dopamine in the system, here, the area of the brain that controls automatic movement doesn't work as well without enough dopamine. So people with Parkinson's often have to think about moving, and thinking about moving makes it very inefficient. So one of the things a physical therapist might do is figure out how to make walking more automatic. And things like walking to music or a metronome can be helpful for that. So these are things people with Parkinson's disease can learn. Like if I walk with music or a metronome, for example, my walking becomes more automatic. The quality of the walking improves. I can walk faster, those sorts of things. And even things like balance exercises. How do you, well, what is the particular issue with balance that you are experiencing? Balance is just a very broad umbrella term, but there's a lot to understand with balance. People can fall in different directions, or maybe not fall at all, but feel unsteady, or maybe only under conditions in which they're bumped. Other people might fall when they reach too far. And those things all have to be addressed differently. And so what a physical therapist can do is identify what are the kinds of balance training that you should be doing, based on your particular profile or challenges. And then the other big thing that all of the therapies can address is how can you stick with whatever behavior you're trying to adopt over time. That's really challenging. So how can you stick with exercise over time? Or how can you eat right, and make good nutritional decisions over the long term? Or how do you stick with your voice exercises? Or how do you just stick with healthy living over the long term? And all of the different therapies that I talked about can help with these things. And it's helpful if they work together and work with you, to determine the best approach. One thing that really struck me, one time when I went to a World Parkinson's Congress, and there was a gentleman with Parkinson's who was speaking. And when he was speaking, he said, I only spend about an hour a year, maybe 2 hours a year with my neurologist or my doctor. And then maybe I spend about 10 hours or so a year in rehab with the different rehab disciplines. So that means I spend the other 8,760 hours a year with myself. And so what that means is that all of the rehab therapists focus a lot on self-management, like how to help people with Parkinson's disease successfully manage the disease over the long term, to optimize function, reduce disability, and enhance quality of life. And so there's lots of different ways to do that. But this is something that, or another reason to access rehabilitation professionals is to develop these skills. Also, there's many more apps that are available now. So figuring out how to use assistive technology. There's apps to help monitor sleep. There's apps to monitor physical activity. There's apps to help with time management if you're experiencing sort of executive function issues. There's apps that can elevate mood, that can help with stress reduction. that can help with speech, communication, for example. And the therapists that you see who have expertise in Parkinson's disease will know about these and will be able to help people access them. So, in a nutshell, what we do as therapists is we want to know what's important to you. What do you value in life? What are your goals? What is it you want to be able to do? What is it you want to be able to engage in? And we help people set goals and develop action plans. Sort of up in the top right here, you can see a goal without a plan is just a wish. So we really help people get specific and really lay out their goals and create a specific plan so that they can be successful. And we want people to be successful and one way to build success is to experience mastery, to be successful carrying out an exercise program, for example, and carrying it out regularly. And then we also recommend in between those visits to the therapist, people need to sort of self-manage, right? And one way to do that is to engage in community programs. And here is just examples of all the different community exercise programs that are available nowadays. There's boxing and pedal for Parkinson's and Tai Chi and dance classes. And all of these work on different aspects of exercise. Some focus more on balance, some focus more on aerobic exercise. They can all be good, for different reasons. But a therapist can help identify what is it that you need to work on the most, or making sure that you're getting the kind of exercise that is most going to be most beneficial to you. And then it's important to, make exercise a habit. How do you sort of make it more automatic and fit it into your life? And so, I know we work a lot with people on trying to build habits. And, what are some ways that we can help people do that? And I don't know if people here are familiar with sort of using nudges. This concept of using nudges comes from behavioral economics, but we apply it in this situation as well. I'll give you some examples. So a nudge is a means of encouraging or sort of directing a behavior without instructing it or without mandating that a person do something. It just you provide a nudge that makes the activity easier, more attractive, social or timely. So for example, in society, putting more, trash bins out, works better to promote cleaner communities instead of putting up signs that say don't litter or you're going to get fined if you litter, for example. So putting out more trash bins just makes it easier to throw something away. Smaller plates nudge people to control one's diet. Instead of counting calories, for example, a smaller plate sort of automatically nudges you to take less, to have a smaller portion. Cities that want to discourage driving can reduce, the cost of a subway and make parking free at a metro lot, right? And maybe increase the cost of tolls. So, there's many things that sort of can help nudge people toward the behavior that they are interested in adopting. Sort of things like meeting friends every Saturday morning at the coffee shop. That having that routine and having a set of friends that are waiting for you, this level of accountability, that's a nudge to get you to socialize and to get out of the house and engage in social activities that, that enhance well-being. There's other ways, other examples of nudges too, like nudges for exercise, like setting out workout clothes at night, putting out your workout clothes with your sneakers. So you practically have to walk over them, in order not to do it, so as soon as you get up, oh, well, there they are. You put those clothes on and then you're much more likely to, engage in exercise than if you had to, go find the clothes, see where your sneakers are, all those kinds of things. Setting a time and a date to walk with a neighbor, that level of accountability, like even an exercise class that happens at a certain time gives you a nudge. An Apple Watch, and you want to see the rings close. that gives you that sort of that feedback and that nudge that, hey, I want to close my rings. And, they could be text messages or, sort of messages that come across your screensaver. I always feel better after I exercise, for example, and that gives you a little bit of incentive to engage. I think I'll just go right here to the takeaway points. So in general, it's important to establish your rehab team. You want to do this as early as possible, though it is never too late. The therapists, PTOT speech, we see people across the whole continuum of the disease. What we're trying to do is get more people with Parkinson's to engage in rehab and to get them to engage earlier. And another thing that's really important is to find a PT, an OT, and a speech therapist with expertise in Parkinson's. That is critical. Just like a doctor has expertise in Parkinson's, like a movement disorder specialist, for example, they know a lot more about the medications than a doctor that doesn't specialize in Parkinson's. The same goes with therapy. Physical therapists, occupational therapists, and speech therapists can specialize in Parkinson's. So you're going to get, somebody that's more knowledgeable. And then be proactive. There's no need to wait until you have a problem to go get rehab. Think prevention, think wellness. It's not just when you have a problem, but it's also when you want to prevent a problem. So think about adopting a secondary prevention model of care or a dental model. Find your expert and engage in regular check-ins. And then, share decision-making. And make sure you let the therapist know, what are your goals? What is important to you? What do you value? To make sure that the therapy is actually working towards helping you achieve the goals that are important to you. So I think I'll stop there and thank everybody, for listening. And I hope everybody has some questions.
Thank you so much, Dr. Ellis. Really appreciate the way that you laid the foundation of understanding the importance of engaging at the start or as soon as we know or confirmed a diagnosis of Parkinson's. I appreciate you outlining that for us.
Great.
We did get a couple of questions. Jim is asking us, can you provide some examples of some of the apps that help with self-management strategies?
There are many, and they're very diverse and they cover lots of different areas. So I wouldn't want to just sort of name ones just in isolation, but it really depends on what you want to achieve. There's a lot of generic apps, and then there's, they can go to the App Store and look at apps for sort of whatever time management or to help you promote exercise, those types of things. But there are others that we find, that are more specifically helpful to people with Parkinson's. But I would encourage you to go, see a therapist and ask about these apps, to get specific recommendations.
It's a great suggestion. Thank you, Dr. Ellis. One of our viewers is asking if you could speak to how rehabilitation therapies can address temperature control in the body.
Temperature control. Yeah, temperature control usually indicates there's some sort of autonomic nervous system dysfunction. And, that is difficult to treat. That's definitely something you want to talk to your neurologist about, to see if there's anything else that can be done, in terms of your medical management that might be helpful there. One thing that is helpful to do is to pay attention to the things that make the temperature control worse and the things that make it better, so you can see whether, this is sort of aggravated by exercise or helped by exercise, for example. And the response tends to be variable. So sort of keeping track of how it fluctuates over the course of a few days and being sort of aware of what things make it worse or better to try to figure out if there's any kind of pattern. Is there any kind of pattern to this? And, and that might help your doctor, figure out, if there's something that can be done on the medical side.
Yeah, it's kind of like a body temperature diary, and then
Yeah, that's right.
And having a conversation with your neurologist.
That's right.
Thank you, Dr. Ellis. Curious, one of our viewers is asking how these therapies can help manage pain related to Parkinson's.
Help manage pain?
Pain.
Yes, yeah, no, that's an excellent question. So pain is actually quite common in people with Parkinson's disease, and the cause can be from a lot of different things. For example, there could be a neurological cause, like something like dystonia. Dystonia, those cramps that can be painful. There can also be, it's very common for people with Parkinson's disease to have orthopedic or musculoskeletal issues like back pain, for example. So it is important, physical therapists more specifically can treat pain and can identify, what is the source of the pain and then what is the best way to try to reduce that pain. Sometimes that can be through exercise. Sometimes it can be through, adopting different postures when people are sitting. It can be related to the way people are moving. So some of those things can be modifiable. So I would highly encourage you, if you're experiencing pain, to see a physical therapist and to try to sort that out.
Thank you for that suggestion. The next question is one that has been a subject of great interest in the community for some time now, and it's related to apathy. And they write, how do I motivate myself to exercise, to socialize, and to do the things that I enjoy? How do I do that?
Yeah, that's a very, very good question. That is actually one of the reasons why we try to build habits, because instead of relying on motivation to do things, which is really hard, it's hard for everybody to rely on motivation. Even people without Parkinson's don't exercise because they're not motivated, right? So when you add to something like apathy or depression, those things make, sort of motivation even more difficult. That's when we really are emphasized trying to build habits, like establishing routines in your day so you don't have to think about it. Like you always, you know, after you watch a certain show on TV, you always go for a walk. Or, when you walk the dog, you always, whatever, take a certain route that's a little bit longer. Or, it's sort of using these nudges and using routines and using the environment to try to make it easier to engage in physical activity and exercise. So it doesn't all come down to willpower, which is very challenging. And so I would encourage you to work with an occupational therapist to help develop those routines and figure out ways you can manage your day-to-day life, such that it makes it more likely that you can be physically active or socialize, those kinds of things. The example I gave of meeting friends every Saturday morning at the coffee shop. So you're not wondering, should I call somebody? Should I try to go to this? Should I, they're already there. They're there, they're waiting for you. It happens every week at the same time. And then people are much more likely to engage.
I appreciate how you highlighted that this isn't just an issue or a challenge just for people with Parkinson's.
Mhm.
Even in my day-to-day life, waking up early enough to go for my morning walk is a challenge for me.
That's right.
Start, Dr. Ellis, of building the habit. Does it start with the willpower? Does it start with the motivation and then it becomes a habit?
Um, Not necessarily, that's going to make it harder. It's like, even sort of pairing things together. Um, for example, people might, let's see, you know, take their medicines and eat breakfast. And those two things are paired together, or eat breakfast and then take their medicines, right? Depending on what works best for them. Um, and those things always go together. So you're always likely to take your medicines because it goes along with breakfast that you're not going to miss. And so if you can figure out how to link physical activity to something you're already doing and it's already part of your routine, and then you sort of pair those two things together, it's more likely to happen without relying on willpower.
Mm. I like the association of the
Yeah, exactly.
sense. One that came to mind for me was preparing my cup of coffee and having cup of coffee and or tea, preparing it while I sit or in meditation in the morning.
Right, exactly.
Would be on the morning walks is the time that I get to have to listen to podcasts or the audiobook that I'm listening to. So this pairing is a really great example of how we can do these things that we want to do and know that we can do and
Yeah.
associating.
The example you just gave about like if you really enjoy listening to audiobooks, that's something you can do while you walk, and so you could pair, okay, I get to listen to my audiobook if I go for a walk. And that, you know, is motivating, right? Without relying on willpower.
And one of our viewers, Jim, says, doing an exercise while watching Jeopardy. Jim, you got me. I was watching Yellowstone while doing the dishes last night.
Yes, yes, yes. Yeah, that's a great suggestion. Sometimes I, talk to people about every time a commercial comes on, you have to stand up out of the chair, take a lap around the house and come back.
Yeah.
And that prevents people from just sitting for hours in their chair, without even realizing how much time has passed. And that feeds into that inactivity. So if you can just respond to a cue like a commercial, up, got to get up, and even if it's just getting up for a couple minutes, it's much better than not getting up at all.
Lulu is writing us and they ask, are there specific exercise for pain in the toes or the feet? This usually goes away once I lay down for bed at night, like, for example, elevating my feet.
Yeah, yeah. So there's no generic response to that. It really depends on each individual person. But that's a very common problem in Parkinson's, the cramping of the toes, and it is something we can help with. So I would recommend going to see a physical therapist that has expertise in Parkinson's disease to learn some strategies, to minimize those things.
Right. All right. Thank you, Dr. Ellis. And we have just a few more comments. Jennifer says, that's habit stacking from the book Atomic Habits.
Yes, yes, exactly. That's exactly it. Well done.
Lulu writes in, I try and go to the gym daily. So congrats.
That's awesome. Going to the gym every day, that is commendable.
It sure
Yeah.
is. All right. Well, thank you so much, Dr. Ellis, for your time today and for sharing your expertise and the work that you have been cultivating for years to allow us to understand the importance of engaging with our professionals outside of our doctors. Really appreciate the perspective you offered.
Well, thank you so much for having me. Take care.
And a big thank you to each of you who joined us today. Please know if you have questions outside of the subject today, do not hesitate to reach out to the Parkinson's Foundation. We do have a comprehensive website and many more resources that addresses everything related to Parkinson's disease at parkinson.org. You can also call our helpline at 1-800-4PD-INFO or email us at helpline@parkinson.org. I wish you all the best. Keep moving and try that habit stacking. I'm going to take that one home tonight. Thank you all. Be well.